Hello, welcome. It's good to have you guys all here. I'm Dr. Lauren Schumacher. I'm one of the child and adolescent psychiatrists on the CalMAP team. And I primarily staff the phone on Mondays and also am involved with the education team. And I'm currently our usual moderator, Dr. Joanne Jung, is at a conference this week, so I'm taking the lead with moderating today. And we'll just wait a minute or two while people are coming in. And if you get a chance, please type into the chat with your name, where you're coming from, and something that you are looking forward to about kind of the November, December, winter holiday season. We'll go ahead and get started. So I'm very happy to introduce Dr. Michelle Riederer, who's a child and adolescent psychiatrist and assistant clinical professor in the Division of Child and Adolescent Psychiatry, and is the CalMAP Associate Director for Community Engagement and Liaison. Clinically, she serves as Director of UCSF Benioff Children's Hospital's Pediatric Psychiatry Consultation Liaison Service and specializes in providing psychiatric care to medically ill and hospitalized youth. So we're very happy to have her with us today to be talking about the introduction to diagnosing and treating depression in children and youth. And in terms of disclosures, you can go ahead to the next slide. None of those involved in presenting or planning have any relevant financial relationships to disclose. And CalMAP is sponsored by the California Department of Healthcare Services and also has HRSA funding. Go on to the next slide.
I can take over from here. Thank you so much for the introduction, Dr. Schumacher, and thank you everyone for joining me today and for your time. So briefly, the learning objectives for today's really brief didactic and then case discussion there's 3 points. One is to integrate and really discuss routine screening for depression and to help differentiate depression from usual or normal sadness, and therefore to be able to diagnose depression. Second, would like to discuss developing a treatment plan for pediatric depression, including kind of an algorithm and looking into when to consider medications, referral to psychotherapy, and consultation with programs such as CalMAP. And third, to really review the first-line evidence-based medications and psychotherapy interventions for depression. So I'll start with a little vignette just to kind of get us thinking about a clinical case. And so this is about a 13-year-old girl named Sienna who already has a history of ADHD and anxiety. And she presents to her primary care doc with increasing irritability, more fights with her brother and her parents. And she's been refusing some dinner, preferring to spend some time alone in her room. She's been complaining also more of frequent headaches and stomach aches to her parents. And she's on occasion told her mother that she feels she's not worth it and believes she's a bad person. I know we'll kind of have an opportunity for a case discussion in the second half of this, but just wanted to get our wheels turning in terms of, thinking about all the different things that might be going on and what you might do in this case if you're seeing this kiddo in your clinic or in whatever practice setting that you're in. So for my talk, we're going to focus more on sort of the approach to depression, including kind of a structured algorithm and how to differentiate different levels of depression, mild to severe. And then there will be a follow-up by another talk with a different project echo coming up that will focus more on the SSRI treatment piece. But I just wanted to start by reviewing how depression in young people can really vary depending on the age of the child and really kind of the developmental age of the child. So it can look really different when you have a depressed preschool age child versus a depressed adolescent. Briefly to review, of course, every kiddo is different and may surprise you, but generally, in a preschool child, they may not be articulating feelings of sadness or low mood, but you may just see something more like them acting not like themselves as much, not enjoying things they used to enjoy, not as joyfully playing. And then once we're in the school age child range, there may be more irritability, more kind of lower frustration tolerance, getting angry really easily, more somatic symptoms. Those are, I think, super common. And one of the ways that, those who are working in primary care may first see kiddos with depression. Often that's stomach aches, headaches, other somatic symptoms that are reported by the kiddo. As well as more separation anxiety. They may even, report hallucinations. And then as we get to the adolescent, that's more of kind of what we think of as, depression in terms of someone endorsing feeling low mood, having neurovegetative symptoms, which, usually describes like sleeping more, kind of isolating more, um, eating more, that type of thing, as well as suicidality. So, again, depression looks really different across the developmental spectrum, and it can look really different person to person depending on whether it's more of a subsyndromal or mild depression to a severe depression. One question that we get commonly is how do we, know it's depression versus just a teen being sad and irritable? And it's true that sadness and irritability can be really normative, and especially during certain developmental stages, such as, adolescence or after, stressors that can come and go from everyone's life. There may be additional sadness. Certainly right now, there are many kind of scary things happening, in our country. And, I think many have reported like having their teens feeling really stressed out. The way to really kind of start to think about clinical depression is whether or not the response to stress, to their stress and sort of the sadness and irritability is causing functional impairment and whether it's causing significant distress to the child. And functional impairment in children really kind of goes across three domains. So at home, with their family, the home life, and then at school, how they're doing in school academically, as well as socially with their peers and friends. If they're having, impairment in functioning at school or socially, they're more withdrawn and not as, not keeping up with their friendships, that might be, a sign that this is more like a clinical depression versus, kind of everyday sadness, irritability, response to stress. And then the level of distress that they're feeling about what's going on, also is a sign. And, whether or not kind of the sadness and irritability is prolonged versus, just kind of transient from moment to moment. I also wanted to make a note that it's important to consider developmental age, and to consider that when you're evaluating a child versus their actual age. And so, for example, we do have modified criteria for depression. If a patient has intellectual disability, there's modified criteria in the DMID-2, which is kind of a, kind of uh, a tool that you can use that is very similar to the DSM, has all of the DSM criteria, but some modifications for intellectual disability. So I know many of you are already doing this in your practice, if you're working in primary care, but screening is really, really important. It's really important to start with asking the question. So the USPSTF recommends universal screening for depression for all adolescents aged 12 to 18 using the PHQ-9A. Here's what it looks like. I know many of you are already super familiar with this tool, and it's a pretty great screening tool in terms of helping you to identify when there's a concern for depression, as well as helping to stratify sort of the level of severity of the depression between sort of mild, which is a cutoff of 5, more moderate, positive screen, which is cutoff of 10, and then 15 and 20 are for moderately severe and severe. So you can remember the 5, 10, 15, 20 for the PHQ-9, and after 10, you've got a positive screen. If you have a kiddo who's younger than 12, then you can also use the short mood and feelings questionnaire, and you can find that on our CalMap website and take a look at that. I know many of you who are working in primary care and pediatrics are already doing your, kind of universal psychosocial screening for teens during their annual checkups. And that can also be a really useful tool in addition to the PHQ-9 for understanding what the stressors are for the child, including if there's any concerns about depression or coping difficulties. So I know the HEADS is sort of the one that many of our pediatric colleagues are doing here at UCSF, but Shades is a wonderful tool that one of our colleagues brought up with us recently as really focusing on the child's strengths. And as I talk about depression, I think often we take, especially in the medical world, we may take more of a kind of an approach in terms of talking about what the challenges or the struggles are. And it's always important to remember to when possible, reframe and also to include the child's strengths in the conversation when you're talking with parents and family about mental health concerns, including depression, and to really take a strength-based approach to kids. So after the screening, we never want to make a diagnosis jumping from screening to diagnosis. We always want to use a screener as a tool, but not as a definitive, sort of diagnostic tool, right? So we have to do the evaluation. We have to talk to the patient and kind of really try to figure out what's going on with them. Using the PHQ-9 and the HEADS and the Shades assessment as possible ways to sort of open the conversation and introduce some of your questions. You could, mention some of the answers that, the teen or child may have provided in the screener as a way to start to, inquire and be curious. Some tips that I like to do myself, always try to talk to the patient and parent separately. For teens, this is super important because they may not feel comfortable. They may feel like, they don't want their parents to know or that it's an additional burden. And so, offering teens the option to speak in privately and letting them know about confidentiality is really important in terms of, getting a real sense of what's going on with them. And to always ask, because teens aren't going to necessarily volunteer their symptoms spontaneously or volunteer sort of what is, happening in their lives and what's causing distress or stress. And sometimes if there is some hesitancy around volunteering spontaneously or answering these questions more, than using normalizing statements like, this is a question I ask all my patients, or, this is, something that, a lot of teens struggle with. I see this all the time. I could imagine how this would be so hard given that your experience, facing this and that. Those types of statements can really help to start the conversation. And if possible, we always want to try to break down silos and understand, fully what's going on. So talking to the parent is also crucial, as well as if the patient has other supports like therapists, counselors, or others who know them well, and there's an opportunity to speak with them, that can be very crucial as well. So once we've done the screener, we've started to talk to the patient. In terms of making a diagnosis of depression, in psychiatry, we use the sort of DSM-5 as the tool to meet clinical criteria for depression. So you may be familiar with this already. The diagnosis for depression includes the presence of either depressed mood or anhedonia, which is loss of interest or pleasure, plus 5 of the following symptoms in this list here, including sleep changes, feelings of guilt or worthlessness, changes in energy level, difficulty concentrating or making decisions, change in appetite, and psychomotor slowing or agitation. And again, just to kind of underscore this point, all of these symptoms can be mild to severe, as depression can be mild to severe. The degree to which the child or teen experiences these symptoms can influence the level of distress they're feeling and subsequently their functional impairment. And we want to take all of these into consideration when thinking about what the next steps are, to best help the child and to guide the family in terms of intervention. Also, when we're doing this in the primary care setting, we also want to keep a broad differential diagnosis, including medical comorbidities and medical differential that can look like depression. So here's a list of, common things, including things that cause, sort of sleep disruption and fatigue and low energy and poor concentration. Um, Medications can also influence one's mood and all of the related symptoms to depression. So it's important to be aware of if the patient or the teen or child is taking any, is using any substances or taking any medications that are prescribed. And to kind of also keep an open mind that even when it seems like it could be depression on the surface, sometimes there can be more going on. And for example, in our particular vignette, we already know that, in that case, Sienna is diagnosed with ADHD and anxiety. And really, the DSM and kind of in our mental health world, we have all of these nice little diagnoses that are perfectly into these buckets. But in reality, we rarely see somebody who fits into one bucket perfectly, and life is messy. And so is, um, you know, um, mental health, behavioral health. And so often comorbidities are the norm and not the exception. It's really common to have depression go hand in hand with anxiety, for example, and other mental health concerns. I wanted to highlight that we have this really nicely organized depression clinical work pathway for those who are in primary care on our website. And if you look at the online web version, there's also these are links to screening tools and more information about safety checks and depression. But this is a little bit of a guide that aligns with various practice guidelines from the AAP, including the GLAD-PC toolkit about depression, screening, diagnosis, and treatment in primary care. So as you can see, the algorithm really starts with screening and then doing more of an assessment, including assessing if there's any safety concerns or thoughts of harm to self or others, broadening the differential to think about other comorbidities, and then using both your assessment and potentially the PHQ-9 as a tool, thinking about, scoring sort of the depression in that clinical encounter as mild, moderate, or moderately severe to severe. And depending on kind of the level of severity, you would consider starting with psychoeducation support and monitoring, which I'll talk a little bit more about in the next slide, and then moving on to psychotherapy if there is limited improvement, and then moving on to SSRI if there continues to be limited improvement, versus in the moderate condition, you would just start with the psychoeducation and support along with psychotherapy. And in the more severe cases, you may consider starting with recommend referral to psychotherapy and SSRI treatment immediately. So there's sort of a gradation here in terms of how many interventions you're recommending at the same time versus more kind of new follow-up along the way. In terms of psychoeducation, I wanted to really highlight so many wonderful resources out there, including the CalMAP website, which we have a specific area for depression that links to provider resources and family-facing resources. So, the AAP has some really nice handouts for families on different mental health conditions, including depression and sadness. And we have a similar, that's linked on our CalMAP website. We also have one that we specifically developed around depression. We're getting more and more questions about this. The CYBHI recent tools, Soluna and Bright Life Kids. So Bright Life Kids is for the sort of youth-facing platform. Soluna is the parent-facing platform. They can also be excellent resources. There's a lot of psychoeducation on there around depression and some of the kind of support and monitoring recommendations, including addressing lifestyle factors, and then some guidance to caregivers and patients on managing emotions can be found there. And then also what's recommended for those who are working in primary care is to, kind of have frequent follow-up, usually within kind of at least a monthly basis when the initial concern, and during those follow-ups to use continued measurement-based care and to use a screener again, such as the PHQ-9A on repeat visits so that you have a sense of how the symptoms are tracking, whether, things are getting better or if things are getting worse, and that can help guide, the next steps for the patient and family. So that was active support and monitoring, which is recommended across all levels of severity for depression. And then cognitive behavioral therapy is the evidence-based type of therapy that is recommended for treatment of depression in that, if they're in the mild, if they're not responding to initial interventions, or in the moderate and severe type of depression. Many of you are probably already familiar with CBT, but really briefly, the core tenet of CBT is that thoughts and feelings and behaviors are all connected in sort of this triangle that you can see in the background here. And how we think about a situation, really sort of the thoughts that come up influence how we act in that situation, and both of those influence how we feel. And really kind of, as we're dealing with mental health conditions like anxiety or depression, the where we feel is the piece that's really troubling, and where we can intervene is on the thoughts and the behaviors. And so ways that we can intervene on thoughts and behaviors, here are some examples using cognitive restructuring. So that would be, for example, working with a patient or a young person on identifying sort of negative thought patterns that come up. I always do this, or I'm worthless, or, this is hopeless, and replacing them with more balanced and realistic perspectives. So really kind of working on workshopping those thoughts. And the other piece is workshopping the behaviors. So that might look like behavioral activation, which is really engaging in kind of positive activities, getting out of the house, going and doing things that the youth enjoys, scheduling things with other people. We all know that when we're depressed, we tend to kind of isolate and do the opposite of behavioral activation. And it unfortunately tends to then become sort of this vicious cycle of isolating, being more alone, feeling worse, and then isolating even more. We want to break that cycle with behavioral activation. And mindfulness also, can really promote some more sort of acceptance and awareness of thoughts and emotions. And also that can impact both sort of the behavioral piece and the cognitive piece. So we've talked about therapy, we talked about active support, monitoring, some tools and psychoeducation for the family. And so a big question comes, when do we, think about prescribing in primary care? Certainly, not every child who's experiencing depression needs to be on a medication or should be on a medication, but there are times when a medication could really make a huge impact on the child's level of distress, their functioning, and really kind of their future. And so we want to help you to identify when those situations arise, when someone could really benefit from medication, and how to go about, with the medication piece and prescribing. Here are some thoughts in terms of prescribing in primary care. One, as I mentioned, is really sort of the level of severity of depression. How impaired are they? How distressed are they? Is this a really severe depression? When it's really severe, we're thinking that, in that algorithm that I'll refer to again, medication may be on the table early on in the conversation with the family and youth. Or perhaps medications on the table later because there's been, a limited response to therapy, there's been limited response to other interventions, and the kiddo is still feeling really down, depressed, distressed, and impaired. Of course, we need to have this in terms of the medication. There should be sort of a patient and family-centered discussion around medication risks and benefits, and to really, take the parent and patient perspective and preferences into account. So joint decision making is really important in terms of medication here. And then just other variables, you should know the patient, you should be able to have follow-ups with the patient so that you can monitor the medication. If this is like an urgent care or a really short-term setting, that might not be the right time for a medication, because as I'll mention in the next slide, there's going to need to be some follow-up in terms of monitoring and titrating, and these and SSRIs don't work immediately. So kind of a longer-term relationship is preferred. And, a plug for the CalMAP program, including the ability to consult with psychiatrists. If you have access to consultation and ability to collaborate, you'll feel better in terms of starting and monitoring these medications. And of course, we have this, nicely sort of organized algorithm, but in reality, patients and families are going to have different feelings about different areas of treatment, whether that's being, not excited about therapy because they've tried it before a few years ago and it didn't go well, or feeling like they would never, try medication. They don't want something that makes them feel different. And so I think, again, that joint decision making and patient-centered care is really important in all of this. If we are thinking about starting meds, here's a few guidelines, and we'll go more into sort of the nitty-gritty in a future Project Echo, but there's 3 SSRIs that I'll cover in the next slide. That's Prozac, Lexapro, and Zoloft. They're very similar in terms of head-to-head trials and efficacy for treatment of depression in youth. And so usually when we try to select one, we go based on past response history, family history, or side effect profile and current coexisting medical conditions. Again, really important to help the family understand that response to these medications will take some time. Usually it's in the matter of weeks, right? Not hours or days. And so usually I counsel that it'll take about 4 to 6 weeks to see some benefit. And usually if you're at 8 weeks at an adequate dose, then and you don't see benefit, then it may be time to consider another option, including changing medications or augmentation. But usually it's a few weeks between the therapeutic dose and improvement, and it might take more than 4 to 6 weeks to get to that therapeutic dose. Generally, we think the SSRIs have been, in studies, have been shown to show a greater benefit in anxiety disorders and depression. But again, there is some good data out there that SSRIs can make a huge difference in depression, if it's the right child. And here's just a review. We do have a really beautiful medication guide on our website that has more details about these medications, but these are the main ones that are FDA approved for use in youth. And so we do use them in depression, even if the absolute, FDA approval for MDD doesn't exist, for example, with sertraline. And here's a titration and your kind of higher typical dose range, as well as your max dose, which is 200, 60, and 20. And just wanted to kind of pause there. This is, again, that algorithm to help guide you through the steps. And of course, like I'm saying, there's, this is a nice algorithm. I'm sure, in reality, patients are complicated and, there can be a lot more going on with a kiddo and family and what supports they have and other comorbidities. And so always recommend, we would love to hear from you with a consultation to, discuss any cases that you're actually seeing. I'll pause there.
Great. Thank you so much. We really appreciate that really practical and detailed summary on thinking through depression. So next we're moving into our case discussion and questions piece. We'll start by taking a few minutes for questions, but while we do that, I want you guys to be thinking about if anybody has a case that they would be willing to discuss. And it'll just kind of briefly share the case, and then we'll kind of talk together as a group thinking about additional information we want to know, and then kind of thoughts about next steps. So briefly, I wanted to share there was a number of questions in the chat, and we also answered a number of them there. But one I thought warranted a little bit more kind of discussion would be kind of thoughts about how to approach somebody who has mild depression. They've had a treatment with psychotherapy, but kind of no or limited improvement. They tried an SSRI, didn't have a good response to that either. Kind of where do you go from there?
Right, Dr. Schumacher, could you say that again? I was looking at the chat and there were so many comments in there.
Yes. So the question was, in somebody with mild depression who's kind of failed a trial of psychotherapy and then failed a trial of an SSRI, what do you do next?
Yeah, that's a good question. So I think, in terms of with every kiddo, we would want to sort of understand everything that's going on. So, um, it sounds like in a case of mild depression, it may have started out mild, it may have persisted and potentially, become more severe. I'm assuming in the case where medications were also started. And, depending on sort of like what's going on, the level of impairment, what the failing of the first medication looked like. Sometimes it's the medication wasn't, would want to make sure that was a real trial. So, for example, add an adequate therapeutic dose. Sometimes that looks like pushing it up to the maximum dose. And then, again, with enough time, sometimes, like I was saying before, these medications can take several weeks, right, to have some benefit. But assuming that it was a therapeutic dose at a really, kind of a with an adequate trial in terms of time, then would want to also, work with a family to kind of understand, um, you know, how they're feeling about things. But along the algorithm, the first failed antidepressant, we would recommend an alternative antidepressant, so an alternative SSRI, but also would just want to make sure that we're kind of capturing everything that's going on, including, what is the psychotherapy that they're getting? Is it effective? Are they getting it frequently? Are there other comorbidities here that are not being addressed? We really want to, again, like, kind of zoom out and make sure we're capturing the entire differential. Is there anxiety? Is there ADHD? Is there something else going on? Are there, stressors at home? What's going on at school? So I think, I guess the really sort of algorithmic answer is if someone one fails one SSRI, we try another because we know that not every SSRI is effective for every patient. And then the less algorithmic answer is to really zoom out and make sure that, we're continuing to kind of do the evaluation every time we're meeting with a patient. Of course, we want to do you want to consider the differential and everything in the initial visit, but sometimes I know that in reality, as we get to know patients more and what's going on in their lives more, sometimes our differential can shift a little bit.
And then another question we have is in rural areas where therapy is inaccessible, would you recommend any online do-it-yourself resources to try before initiating medication therapy?
Yeah, that's a great question. So I think there's a lot of different value in sort of kind of the different interventions that we can make in a child's life. And so sort of like, individual in-person psychotherapy is well studied in depression, and it's, one of the great sort of evidence-based tools we have for depression. And the reality is not everyone can, have access to that and is able to meet with somebody. I think depending on the level of severity of the depression, as I showed in one of the previous slides, like with milder depression, potentially, kind of an online resource like Soluna or Bright Life Kids could be, a helpful starting point. There's also, more and more options for kind of virtual therapy, depending on, whether the patient has Medi-Cal insurance or commercial insurance. There can be different options that they can access in kind of these different areas. And then depending on the severity, there's also more like virtual IOP type programs, which are even sort of higher intensity in care, kind of more frequent with kind of different types of programming, but also virtual. But I think in those cases where, someone is having difficulty accessing, sort of what we recommend first line in terms of therapy or has tried medication and things aren't helping, that's a really good time to also, talk to CalMAP. We have wonderful care coordination resources too that we could help identify the resources that might help a child in a particularly kind of under-resourced area.
Yes, it definitely is a challenging situation. And I also appreciate Dr. Steinbushel in the chat also mentioned kind of emphasizing those kind of healthy lifestyle aspects that I think in primary care you guys are especially well equipped to address in terms of sleep, eating, exercise, and that those all can make a big difference too. All right, I wanted to check anybody who has a case that they would like to share and discuss.